So adaptation. You want to demonstrate adaptation? Fine. Can we get 2 pens? Pen. So 2 pens, huh? So I'm just demonstrating because doing smooth pursuit will be taken seconds we can do, right? Yeah, catch. I've already showed you that in the past. So basically, this is saccadic she is doing. So she will be keeping two things in her eye, fixating there. So will be like this, then up and down and on the z-axis. Show. So one will be x. Huh. She is moving like this on the pinpoint focus. Then she changes it to, keep it like this. Huh. Okay. Verticality. Okay. And then she can make it like this, z-axis. So because all the three canals come into involvement of the XYZ movement. You can also see we have used a playing card, we have used help of this playing cards, because वो राजा रानी का फिगर भी है ना, उसके ऊपर फिक्सेट करोगे तो भी हो जाएगा. जो आपका ये है ना स्मूथ परसूट में we generally prefer you having something like a placard which is having alphabets like a Snellen's chart or a reading card at the time of this near vision assessment. Near vision जब assess करते हैं give you a card जिसमें बड़े-बड़े letters से छोटे-छोटे letters लिखा रहता है. तो basically you have to read through those lines like this. Okay, and then you can have the smooth pursuit. Now coming to the VOR1. Show VOR1. Take only one pencil, na? Don't pick two. So in VOR1, in VOR1 what she'll do? She'll keep it like this and just move her head around this. This will be stationary. But in VOR2, if this goes on this side, this will go on the opposite side. Okay? Yeah. This is VOR2. You want to demonstrate? You want to show? Okay, this is VOR2, but a bit slow, because your balance system also has a frequency from 0.5 hertz to 6 hertz. So, वो graded fashion में improvise होगा. No, only one direction. Okay? So, you can then change the direction, change the speed, change the frequency as and when the patient starts bettering. Okay? So, these are your basic adaptation exercises. This is habituation. Now, what you have to do now? Pencil lag de. Okay. Now, what you have to do is horizontal head movement. So, what you will do is ask the patient. This is an exercise. So, this is along with the adaptation. Start with habituation. So, move your head in the different directions. So, right, left, up and down, and towards the shoulders. Okay. Yeah. And while walking also, gait with head turns. She can walk like this. So, go slow. Go slow in the movement. So, the compensatory mechanism will happen. So this is how you start. You start with adaptation, go with habituation. Initially I mentioned a word known as unstabilized, stabilized, compensated, uncompensated. So these rehabilitation is the major goal is to have a compensation, not stabilization. Stabilization will happen with drugs, but 2 steps ahead will help the patient to get rid of the vertigo entirely. The entire balance system goes off. It goes normal means everything becomes normal. This is substitution protocol. So basically, this has to be handled by our physiotherapist. So once the patient has become stabilized, they want to increase their speed, they want to get rid of the bradykinesia, they can do it on the physio ball, they can do it on the trampoline, they can do it on a foam. We have dynamic posturography, but that's quite expensive, So that all is done in all major countries, or maybe in India, major tertiary care setups where they change the surface only changes. Okay, so if you can have these videos, there are many equipment like physio sensing and all that, they have it, but it's very expensive, But this can be done as a routine protocol. They must be doing as a routine protocol. For them, it's not a big deal. And on that also, they can practice Romberg's, tandems. So that is for practice. So this is for rehab, this is not for assessment. So there's a difference. Okay? So, okay, thanks, Divya. I'll see for Simons. Yeah? So brain cannot fix it, body it cannot see. So the new normal has to be the assessment. The first thing is the patient has to be free of BPPV. With BPPV, you cannot do a rehab. Because then you are spoiling the condition. Your BPPV should be dead sure clear, then you go for the baseline and then you go for the clearance. No movement, no improvement. If you don't move, you are not going to improve. So if patient बोलता है मुझे थोड़ा सा अरे आने दो, but it will break that cycle. 3 weeks में the cycle will break. Okay, focus and concentration makes it better, and cognition is very important too. Like if the patient comes, you want to ask now what is the date, what is the color of that object. In your OPD only, what is this? You will understand the cognitive dysfunction mainly in old age. And if you feel that only this neuroprotective agents will not help, you can always have a cognitive rehabilitation also. Okay. Now some part on canalith repositioning which I want to say. This is the last part, and my Simons is left, I remember. So BPPV and atypical variants of BPPV, individual anatomy and spinal abnormality. That means if the spine is not up to that mark, you choose the maneuver based on the patient's anatomy. If the patient's neck is very rigid, you cannot attempt an Epley's. Don't think you may induce something else. So only if it is free of that movement, only then go ahead. So patient is pregnant. If it depends upon the trimester she is on. So based on that also you will pick up the maneuver which is comfortable with her and you. Don't, just because someone has told that this should be done, that should not be the case. What is your comfort level? Because this is your patient. That is how it should be done. Diagnosis I've already mentioned. I've showed you also disc sulpike, supine roll and deep head hanging. And treatment is again maneuver, symptomatic treatment, vitamin D and follow-up. So this is going to remain the same because I keep on writing this thing again and again. And thank you so much for patient hearing. My Simmons maneuver is left. Shashi, aaja. We have given this काफी rest हो गया table का भी. Gloves. Okay, so this was the last segment. I would request, if you have any questions along with your friends you want to ask, you can ask. Was the last part which is left for me to show it to you all. Always remember, Brand-Daroff exercises, you stimulate the canal on the side you are giving the patient. So if BPPV says one side, one canal, how can you give Brand-Daroff as an exercise to the patient as a rehab? So Brand-Daroff is not the technique that should be used. It is double Simmons, double of Simmons. How? I'll show it to you. इधर आना, आगे से. हमारे क्या हल्के से बैठ अभी. Okay, so now what I'm going to do is, my side lying method which I did initially, fold hand, turn this side and I'm going to take him down. Now I got it, I have got everything positive this side. Now from here I'll take him, like Sashi, dheere se jana. Go slow and we'll take him down like this. So this is my 180-degree turn for Simmons. And then maybe I will do a canalis jam thing that I will move his head here only. Or I will take him up, get him down and then do the canalis jam. So I prefer to do either of them on either of the two steps. But remember one thing, what is Brand-Daroff? Brand-Daroff is actually this Simmons maneuver. But that's not correct because that means the right disc sulpike got tested on the right side, and then the left disc sulpike is opening. You're stimulating both the canals if you're just giving Brand-Daroff. Brand-Daroff में दोनों रहता है. So it is double Simmons. Twice of what you're saying as a rehab. So it's a wrong measure. Thank you so much. Okay? And questions are invited. Yeah. No, clockwise, anti-clockwise are not advisable.
We are doing in normal. Does it have some preventive role? We should go on.
Not the clockwise, anti-clockwise. Do the normal head movements. That is good ergonomically also. So you cannot be on the computer for the full time if you are working or be on the mobile.
We are talking about normal person.
Normal I am talking. I am also talking, but not that round wala movement. No, not this. No. Rest everything is okay. You can always reduce the trapezius pain. Sir, I have not told. Sir, whoever is saying they are responsible for the consequences.
How is the mobile affecting nowadays?
Huh?
The young generation, Gen Z, mobile use of
Gen Z's,
Yeah.
I have one more research.
Yeah.
But Apple will screw me legally. iPhone users have maximum migraine. And second are OnePlus. Samsung won't. I don't know why. It's a common finding.
Screen time and the neck position.
Yeah, then you have to use the principle of 20-20-20. 20 seconds of the screen time, and then 20 seconds off of this. Like 20 minutes of the screen time, 20 seconds off, 20 minutes of long distance. You can use this principle for migraine. If you're on a full time, you should always use a blue coating glasses.
Hello.
The same.
What is the commonest diagnosis in vertigo in children?
Benign, this childhood is migraine only. So, but BPVC we call it, benign vertigo childhood, but it is because of migraine. But there can be major stressors also in this. Psychological counseling can also be there. There can be squints, strabismus, ear conditions that can be overlay. But mainly if you see, they will have thyroid abnormalities also. So So pediatric population, more of this. Latest I had a case of familial hemiplegic migraine where the dominant gene autosomal came out to be positive. But I'm not expecting any findings and they have already put them on topiramate, which is a drug of choice. So that's very much okay.
And you know, it's earlier pathology will be very common again in pediatrics.
But then that has nothing to do with vertigo, na, ma'am, as such. Of course, you can always clear it up. I mean, you can give mometasons and nasal drops and your routine in this management by fexofenadins and all. But then, ठीक है ना, I mean, that should not be the cause of vertigo. Middle ear congenital cholestoma, yes.
Performing maneuvers in cervical spondylosis with rigid neck.
I will not do it.
Conservative.
I will not perform. No, I will first put the patient on physiotherapy.
They
Because sir, if the patient is having spondylosis, they will not allow me to touch it. I will not aggravate the pain. So I will try to do the assessment. If I am not getting, I will do the side-lying method. If still there is pain, I will not do it only. I will not put the pressure on the neck. I will put them on physio, call them back after 1 week and see if they are in a position to assess. And then I will do the routine first of all.
Regarding Meniere's, what is the minimum duration you give beta-histine, or is there any protocol?
So from first Meniere's is I would like to differentiate whether it is having a migraine component or not, as mentioned. If I am not feeling, then I will pick up the diuretic. And now I want to give a weak diuretic like chlorhydron, or I want to give a diuretic like Diamol, which has a potassium outflow. I want to give for furosemide. Depending upon the condition, I will decide on that. Beta-histine, I generally try. I am the one who stops the drug. Basically, I love stopping the drugs. So basically, I will start on 48, taper it down, call the patient after 20 days, taper it down to 24, then further try to bring it on 16, try to eliminate and force the patient to go for a lifestyle dietary modification.
How long this tapering should continue?
Should be 6 to 8 weeks, to my understanding. Minimum 6 to 8 weeks is what, but depend case basis. कितना क्या खराब उसका रिपोर्ट आता है